This podcast is a production of OPENPediatrics, an open access online community of healthcare professionals sharing best practices from around the world. Visit openpediatrics.org for more.
Hello and welcome to the OPENPediatrics World Shared Practice Forum podcast series. I'm Kate Madden, a PICU attending at Boston Children's Hospital, and it is a great honor to have with me today Dr. Sapna Kudchadkar, Vice Chair for Pediatric Anesthesiology and Critical Care Medicine, and Anesthesiologist in Chief of the Johns Hopkins Children's Center. She's also founder of the Johns Hopkins PICU UP Early Mobility Program, and a professor of anesthesiology and critical care medicine, and pediatrics and physical medicine and rehabilitation. Sapna, it's a great pleasure to have you here today on our podcast. Thanks for joining us to talk about PICU UP and early mobility in pediatrics.
Thanks so much, Kate. It's awesome to be here.
I think what a lot of listeners may be thinking are in the position of not having any early mobilization or structured early mobilization program in their PICU. So if you could speak a little bit to how does one get started? How did you get started? How can you approach a structured early mobilization program?
Thanks. That's a great first question. And I think that's the first question everybody should start with. So I'll just go way to the back when I didn't anticipate that anything about my career would involve early mobility and critically ill children. I started, in my PICU fellowship, I was really interested in sleep hygiene in the PICU because I'm an anesthesiologist and, obviously I'm really passionate about sedation and how all of that interacts. And I noticed that kids were just, laying around with their eyes closed and we kept saying they were sleeping. And that didn't make any sense to me because I was like, well, they're pharmacologically sedated. Is that really sleep? Is that what kids need when they're developing and their brains are developing? So then I started to investigate sleep, but I was way over my head, right? I'm not a sleep physician in addition to being an anesthesiologist and intensivist. So I started doing EEG and power spectral analysis. And while all of that was really exciting, it was clear that for me, the clinical relevance came in. What are the actual interventions we're doing at the bedside to optimize care and normalize, if that's the right term, right? Normalize isn't really a term we use in the ICU because nothing's normal about the ICU, but to normalize routines as much as possible. And it actually, I'll be honest with you, that PICU UP and early mobility actually wasn't my idea. It was from one of our nurse practitioners, Beth Wieczorek, who worked at the Kennedy Krieger Institute when she wasn't a PICU nurse practitioner in the neuro rehab unit. And she said, Sapna, we focus so much on intensive rehabilitation after brain injury, and these kids come here and rehab, PT, OT. But then they're in the PICU for weeks and months and they're just laying there. And what's happening? I was like, OMG, I think that we need to do something about it. And so then we did what you always do when you don't know the answer to an issue or whether there's something out there. We did a literature search and we found exactly 5 studies focused on anything related to acute rehabilitation in the ICU environment. And that's how PICU UP was born. So if you want, I can share a little bit about how the whole process started.
Yeah, that'd be great.
So essentially, once Beth and I decided we needed to do something about this, the systematic review, which we did publish, did identify these 5 very heterogeneous studies on various patient populations. And so then we said, okay, well, clearly this is an interprofessional process. We can't do this without a physical therapist, an occupational therapist. So we got someone from every single discipline that in our minds was directly relevant and related to optimizing ICU rehab outcomes in a room. And so it was physicians. And I'm telling you who these people are for a reason, because you make mistakes along the way of any implementation study or project. We had a physician, nurse practitioners, PT, OT, respiratory therapy. And, we at the time didn't even think about child life. I mean, go figure, right? Play, normalizing routine, but child life wasn't in the room. But that's how PICU UP was initially born. One of our senior intensivists said we needed a cool name, and we just sat around for an hour, came up with a cool name, and PICU UP came to be.
That only took an hour. I feel like that's such a genius name.
It was just, we were just sitting around staring at each other. And then Dr. Ivor Berkowitz, one of my mentors, senior colleagues, said, what about PICU Up in a South African accent? And it was wonderful. And we were like, oh my gosh, like how did none of us think of that first? So after we came up with the name, we essentially noted that there was nothing out there published for us to follow. Like we had no framework or algorithm to follow. So we met weekly for a year to come up with the PICU Up program. And essentially we started with this process of getting feedback from the direct stakeholder groups. Every stakeholder leader would go back to their RT champion and go back to the RTs and ask, what do you think about this? What should we do? Then we came back together, developed this program that we thought made sense, figured out we need child life specialists ASAP, and then created a protocol and a policy.
Wow. So really, that is such an interdisciplinary and collaborative and democratic, really, process for getting so much input. How, having gone through that process and spent all of that time, what do you think? And then you have obviously distilled in the PICU Up program that many other centers have adopted these elements. But what do you think, would you say to a center are the essential elements that you need in terms of representation and inclusion and participation in order to make this a success?
Great question. Interestingly, the Society of Critical Care Medicine ABCDEF bundle and the ICU Liberation Initiative was simultaneously emerging around the same time that we were doing this PICU Up work, but only in adults. So at the time, I had actually not been connected with that initiative. And then it all just kind of came together about a year or two in that they were advocating for the ABCDEF bundle. So as many of you who are listening know, the ABCDEF bundle encompasses analgesia, breathing, spontaneous breathing trials, choice of sedation, delirium monitoring and management, early mobilization, and family engagement. And so once we created the PICU Up program, we realized that it really incorporated and integrated every single one of those things. And the goal of PICU Up was really not to get patients ambulating on day zero of their PICU admission. We wanted everyone to recognize that early mobility is a spectrum and that you should do the most that you can for every kid every day. And we recognized that choice of sedation was our biggest barrier to all of it, as I'm sure you know very well also.
I think that may be universal, at least in pediatric critical care.
It absolutely is, because many of you who are listening probably know that often the goal is to have a state behavioral sedation score or a RAS score in the chart that's documented by the nurses. But what we found is that our nurses were doing an incredible job documenting because they had to. Like it was something that needed to be done. But the medical team was doing nothing with that information. We were just like going about our day. Oh yeah, let's increase the midazolam drip. Again, we'll get to midaz in a second and benzodiazepines, but let's increase the midazolam drip to this and the opioid drip to this. But you didn't know what you were titrating to because we didn't have a shared mental framework of what the SBS goal was, just what the SBS actually was in our case. And so we discovered that choice of sedation had to be our first stepwise implementation of PICU Up. If we weren't speaking the same language with regards to sedation, then everything else was going to fall to the wayside. So that became our first kind of mini quality improvement project within the larger quality improvement project of PICU Up. We also recognized that delirium screening, forget doing anything about it if delirium was present, but that we needed to first just start screening consistently. So between those two things, I think those were the most important to get to the E. So the C and the D to get to the E. The A, luckily, we're pretty good at universally. I think PICUs do a really nice job of optimizing pain control, addressing children's pain. Breathing trials now there's multiple collaboratives focused specifically on whether we are extubating children efficiently and safely and expeditiously, doing ERTs, et cetera. And then the F just comes naturally, right? We know that almost every ICU in the United States, at least, allows family presence at the bedside 24/7. Now, our colleagues internationally don't often have that luxury, so it's not something that's universal. However, for our state, we were okay on a family engagement perspective, but we weren't including them on rounds consistently. So we brought them onto rounds, asked them to engage, tell us what they wanted, and also started setting expectations about what PICU UP meant. So when a child is admitted to our unit, we immediately make sure on day 0 that families know sleep hygiene is really important here. We're going to open the shades at the time that your child normally wakes up in the morning. Even if you haven't slept well overnight, please know that this is the best thing for your child to have their circadian rhythms normalized. We're going to get your kid out of bed because we are a culture of illness doesn't mean stillness. And we promise that the ultimate goal of that is to get your child back to their home baseline as soon as possible, potentially even before they get discharged home. So while I'd love to say there was 1 or 2 elements that were most important, they're all so integrated. It was really hard to pick just one, but the choice of sedation was clearly the starting point for sure.
Oh, that's so interesting. I was sort of thinking more kind of in terms of what personnel you need, but actually it's really going further back to where are we in terms of the whole bundle and these very interrelated elements. And, how can we lift for this particular bundle element when we haven't got the groundwork of all the other elements in place?
Right.
But they are also so interconnected as well. Obviously, if you're doing early mobilization work, we all believe that that is part of preventing or even treating delirium in terms of activity, day-night cycles, those kind of things. But you also have to have the framework in place to be able to assess. And that takes obviously a lot of resources. So what resources did you find that you needed? Both people resources and other resources in this journey of getting PICU UP off the ground?
Absolutely. So as all of you know who are doing work in hospitals across the world, a hospital isn't just going to hand you a bag of money when you say you have a cool idea or you think is a cool idea and say, go for it. That sounds amazing, right? Everyone wants proof of concept, but not just proof of concept, but proof of benefit and outcomes. So when we went into PICU UP, we went in with the very rational approach and pragmatic approach that if we wanted to get resources for this, we needed to do something first and prove it. The key here in terms of resources was getting buy-in from leadership that this is something that we're all committed to, buy-in from multi-professional leadership, right? So nursing leadership had to be on board, physician leadership, RT leadership, all of those people, because if the folks, the stakeholder champions, if they didn't have the support of their supervisors, none of this was going to happen successfully. So that was the very first step. The first thing that people ask is, are we going to hire more PTs and OTs? Well, no, because again, we haven't actually identified the best and most efficient way to utilize those people's expertise. And right now, we're not even inviting the PTs and OTs into the unit as much as we hope to. So let's figure out what our needs are first, start with the lowest hanging fruit, and then decide what our resources are then and create a business plan and do all of the things. So really our resources were person power and passion. Those were the 2 things. And I know that sounds very soft and fluffy, but
No, it's the recipe to a lot of success, I think.
you need passion. And initially, I was really worried that I was asking these incredibly busy clinicians, because this is a very clinically based program, right? I was asking people who already maybe feel like they have way too much to do in a given day to do more. And what I found was that giving people this shared purpose among the interprofessional team and making them feel like they were part of the decision making, that their opinions mattered, that actually led to this whole other level of passion and initiative and ideas. And that is really what drove the first phase of PICU UP. So if you read the paper that was published, our first quality improvement paper, single center on PICU UP, it was an online investigation in peds critical care medicine, really kind of, I don't think was meant to have as much impact as it did, but this single center study led to really huge things. And if you look at the authorship byline, The authorship byline includes every single person that had a meaningful impact on the implementation of PICU Up, and those were all the stakeholders, including the people who were instrumental in developing our online module for PICU Up, for example. It was really important that all those people felt that their value was truly valued, and that was the initial resource. And then maybe later we can talk about kind of how we got to the business plan piece of it.
So that kind of leads me to maybe a difficult question to answer about passion and engaging with folks. You've been going all over the country and all over the world talking about early mobilization and helping folks get programs off the ground. Do you have any advice for folks who are trying to engage with the passion of their colleagues at a time when maybe, as you said, it's already an overworked group of people, and then maybe there's a little bit more general burnout or fatigue out there in the world already?
I think this is the most important question that we can ask right now. I think we all have this, whether we state it outright or not, some of us are more vocal than others, this underlying sense that people are really exhausted. And the pediatric intensive care environment, whether it's PICU, PCICU, is getting more complex. It's more acute. People are being asked to do more. Clinical service is increasing. Call burden is increasing. And that's because the children are too sick to not have an in-house call attending and, high acuity centers, all of these things. So that's just the physician side of things. And then on the nursing side, obviously there's lots of turnover in many centers because of the current workforce push and pull and the market forces. There's lots of different factors playing into that. So my most important advice for anyone who just is starting from ground zero, they're looking around their unit, feeling the same thing that me and Beth were back in 2014. This is our 10-year anniversary of PICU Up here in 2024.
Oh, congratulations.
Thank you. Is essentially to make sure that you know who you trust and who your partners are already in the unit, and to share with them your why. And I find that the why is often all you need is to show them some videos and some perspectives from other centers of why this is so important. And so I think that those things visuals play a really important role. Stories play a really important role. And then if you're still getting trouble with the why and getting people to buy into, can we sit down and have a meeting about this? Then you just start individually with the lowest hanging fruit in your unit. So don't start with the intubated kid on 80% FiO2 who tries to desat and Brady every time you touch them, right?
Yeah.
Start with the kid who's on 6 liters of high flow nasal cannula. Maybe it's a baby, maybe it's a toddler, and maybe just ask, can that kid get out of bed into mom's arms today, right? I can't emphasize enough how much we don't utilize therapeutic cuddles in the ICU.
I agree.
The NICU is awesome at it, right? Our NICU colleagues, kangaroo care is like their bread and butter. It's foundational to everything they do. And then for some reason, as soon as you turn like 6 days old and you're in the PICU, we're not asking mom if she wants to hold her child or dad if he wants to hold. And we all know that parents are overwhelmed by the ICU, and they are not going to ask you because they may not think it's okay to ask, can I hold my child? So look at each kid in your unit and say, what is the most that I can do safely or prescribe safely for this kid this day based on the resources and acuity of my unit? So if there's a kid sitting around on 10 liters high flow, a teenager who just had a VATS, right? Maybe you can find an exercise bike. Maybe if PT can pull an exercise bike into their room and they can do a little exercise with the PT's approval, for example. So there's always something more we can do, even with the resources and the time that we have. And so I promise you that even if you have no support from anyone else in your unit because people are just too overwhelmed, if you start making those little changes, people will notice. And then that one nurse who saw that kid get on the bike or get out of bed to mom's arms will be like, oh, can I do that for my patient tomorrow? And slowly but surely that culture will start to change. And then you will be able to get everyone in the same room to talk about this thing because it is so important.
Well, and also it's the accomplishing it is really important to show people the safety, but it also feels so good, right?
Yes.
I think this is, something I talk about a lot to the staff. I think it actually is a balm against some burnout and frustration. You get to have the accomplishment of getting your patient out of bed who's been in bed for weeks, or you get to have a mom or dad hold a baby who hasn't been held for some time. I think is the most powerful driver of participation in the program.
Absolutely. And we have data to support that. So 3 years after PICU UP was implemented, we wanted to study it on a multicenter level, but we realized that it wasn't enough just to like run around telling everyone, oh, everyone loves PICU UP in our unit. It's amazing. You guys should implement it too. We realized that we needed data in order to support that. So we did, it was my first foray into qualitative methods, and we did a mixed method study. And we interviewed 50 staff members across all professions in our PICU who had any involvement in PICU UP in any way, shape, or form. And some of them had been with PICU UP since inception, and some of them were relatively new to the unit. And so we got a nice broad spectrum overview of how people felt. And the resounding message was absolutely there are areas for improvement of PICU UP. We found that on the improvement side of things, people wanted simulation, people wanted consistency between attendings, like all of those things that, are no surprise, but it was great to hear and great to have documented. But what was actually, I shouldn't have been surprised by this given how much I love the program and I'm passionate about it, but I was surprised and relieved to see that the overwhelming message was PICU UP is bringing value to our patients and their outcomes in our minds. But even more kind of surprising is that PICU UP brought additional meaning and value to my day-to-day work. And to see a child up and awake and alert, interacting with their parents with an endotracheal tube when they're critically ill, even if their outcome ended up being poor because of their prognosis, et cetera, it meant so much to be a part of it. And initially, some of the nurses actually stated that they were worried that it was just going to be a ton more work, right? It is more work to take care of a less sedated patient.
Yeah.
But then they found that brought meaning and value. And I'll just tell one interesting and funny story in retrospect. One of our PICU fellows got called to a code, and she's actually one of our biggest PICU UP champions and has always been passionate about PICU UP. And she asked the nurses and the family whether they would like to pursue holding their child that day. And the answer was, oh, this is a sick pulmonary hypertension baby. I don't know. It kind of stresses me out. But you know what? You think it might work and it might be okay. So let's try. And so everyone was on board. So about 2 hours later, the fellow kind of steps away and is doing other things, and the code bell goes off in that room. So of course, her initial thing in her mind was, oh gosh,
Yeah.
I know what this is. Like the kid went to mom's arms and immediately arrested.
Oh.
She gets to the bedside and it's like totally quiet in there. There's like not that much activity going on. And the reason they pushed the code bell, because the baby's heart rate dropped by 25%.
Oh, wow.
And it was acute. It went, so low, so quickly as soon as they transferred into mom's arms, but the oxygen saturation stayed exactly the same. In fact, I think they went up a couple points, and it was because the baby was comfortable. There was something happened on the sympathetic surge that went away, and that baby parasympathetics took over in a good way. So we noticed that, we celebrated it, we talked about it, and now people get that like therapeutic cuddles can have physiologic impact, but it's not always bad. It's actually usually pretty good.
Yeah.
So it was amazing to see.
Yeah, I think that one question I have for the PICU UP program in general is that there seems to be a little bit of, as you noted, in PICU, maybe we're have a more of a tough reputation, and we're, a little bit more hesitant to prescribe or talk about therapeutic cuddling or having positive touch, whatever you want to call it, the
Sure.
interventions with patients. For the patients who can't be mobilized for whatever reason, severe restrictions or just physiologically can't tolerate being moved, is a kind of more structured and kind of PICU up approved approach to therapeutic touch in the horizon. Something I'm really interested in, but it's a little bit hard to get people on board.
Absolutely. I think, and one of our biggest challenges, right, is the wide spectrum and heterogeneity of ages and development that we have, A. And then B, there's obviously the complex patients at baseline, chronically critically ill patients at baseline, and then they come in and then they're incredibly sick, for example, if they have ARDS or other things, and obviously other restrictions, whether it's burn patients or, severe orthopedic injuries, all of those things. One thing at baseline that is always PICU up approved is obviously, maintaining sleep-wake hygiene, even if it seems like it's spitting in the wind, right? Oh, we opened the shades today. Like that was all we could do for this oscillated and neuromuscularly blockaded patient who's on 100% FiO2. It's really hard to study this. It's really hard, but at the same time, we are achieving a lot just by those very basic interventions. And like opening the shades, yes, it may only get to the patient in a certain level, but then what about the family that's exposed to more sunlight? What about the nurse in the room who's exposed to more sunlight, right? So that's answering your question at a more basic level. But on a more complex level, we are going to have to do more titrated rehabilitation therapies that are specific to patients. There's no question. And in fact, myself and Dr. Nilesh Mehta, who you know very well at Boston, have a trial ongoing looking at kind of PICU Up Prime. So PICU Up that is not just the standardized PICU Up program, but how does PICU Up with intensive and individualized rehabilitation therapy make a difference in combination with standard versus high protein, for example. So we have to look at individualizing therapies because every kid in the PICU is so different. And with regards to touch, yes, some children may actually not have a positive impact with therapeutic touch. That might not be the right answer. What is the role of music therapy? What is the role of all these other non-invasive, relatively inexpensive modalities that we have? How do we implement them in a way that's meaningful, not too onerous for the staff, and becomes more than just feel good, right? I think people think music therapy is a great idea, but how do you show that music therapy truly has a positive impact on outcomes in the short and long term? And what do those outcomes look like? Because I don't think it's length of stay or duration of mechanical ventilation. There's something else there that we need to capture.
So Sapna, you've talked a lot about the various resources that are needed to get a program up and off the ground. I wonder what you've learned about sustaining a program over time and past the initial excitement first couple of years.
I love that question, but it's also a really hard one to answer because we're actively addressing it like minute to minute and day by day. So implementation is exhausting in and of itself. Sustainability may be even more exhausting because it is really hard. There's no guarantee that you are going to remain in the same place for decades on end, right? Luckily, I've reached the 10-year anniversary of PICU Up. I'm still here, right? But you can't assume that. What you need to make sure is that culture change doesn't rely on one person, right? There's no way that culture change can rely on one person always being present. You need to have a succession plan, A, in terms of leadership, and B, you need to have such a foundational impact on your culture that it's like continuously feeding itself. So I and Beth and our other champions should be able to disappear for 6 months and come back and see that kids are still moving. Yeah, maybe we've lost a little bit of the formalization of the process, but the culture is still there. So what I encourage everyone to do at baseline, let's say you've implemented, you're having great success, you're very happy. Don't rest on the laurels of this is our champion team and we are just going to continue to push, push, push. You need new energy and you also need new ideas. So new ideas don't generally come from the same group who's doing the same thing. So one thing I learned very quickly is that as soon as I saw a nurse on rounds, and we do one of the key components of PICU Up is nursing centered rounds. The nurse has to be available for rounds. We center everything around the nurse because they're at the bedside the whole time. and they present the information, and then we collaboratively discuss the assessment and plan. So if there's a nurse who does an incredible job talking about the PICU up levels and the early mobility goal for the day, I reach out to him or her afterwards and say, hey, like that was amazing. I give them feedback in real time on rounds, but then I also say, are you any interest in joining our PICU up committee? Would love to invite you to the next meeting. And almost always the answer is yes, or yeah, please let me know when they are. And I'm absolutely join when I can. That way you get the people on the ground engaged. The other key to sustainability is to really, really emphasize and optimize the relationship between nursing and the rehabilitation team. So I know you've heard me say this before, but you almost want the physicians to become irrelevant in the sustainability of this process because it's just happening on its own because the therapists and the nurses have a relationship where they are calling each other, collaborating on what time they're going to mobilize this kid on this day. All of that is really important. So finding ways for them to network and connect. And then also another key to collab, and this takes time for the leader. So I will keep that in mind as I share this with you, is finding opportunities for the interprofessional team to get out of their bubble and share what they've learned and what they're doing with their own colleagues on a national and international level. So what does that mean for a physical therapist? It means finding a way for them to present a case report or an abstract at the APTA meeting here in the States, or the AARC meeting for the respiratory therapists, right?
Mhm.
That has been incredible for sustainability because, believe it or not, when people find that their personal academic aspirations or careers, even if they never anticipated having one, if they're getting a chance to kind of wet their feet with that, it's amazing what can happen with innovation and ideas.
Yeah, I think that's something that maybe is not emphasized as much in the multidisciplinary collaboration as the emphasis on, the scholarship and, quote unquote, like sort of traditional academic success for all the different disciplines. I see that.
Absolutely. It doesn't mean a respiratory therapist at a typical academic center isn't looking to become a full professor, potentially, but they would love to present an abstract or a case report on this innovative thing they did with one of their patients. And then they will start to talk about it with their own RT colleagues, bring in more champions. That becomes really important. New energy is key. You need new energy.
I think that's really great advice, and I think one that we will certainly I will take back to our team here. That sometimes it can get a little bit insular, and it's important to keep inviting new folks in. With all of your great work over the last 10 years in creating the PICU Up program and all the scholarship that you and your group have produced, and others in the early mobilization in pediatric critical illness, what have we learned about early mobilization in PICU to this point?
I think we're on the precipice of a lot of really important data coming out in the last month in terms of everyone wants to know about outcomes, right? Does this stuff make a difference? Does liberating critically ill children using the ABCDEF bundle make a difference now that we have a name for it, regardless of whether you call it PICU Up or Move or whatever the name of your program is? The evidence that we have right now regarding outcomes is the large collaborative that was done by SCCM, the Pediatric ICU Liberation Collaborative, that was recently published in Peds Critical Care Medicine, that showed that there was actually a signal with regards to mortality benefit with implementation of the bundle. The challenges there are, in terms of applying that to our current practice, is that each of the bundle elements was implemented in a different way at each of the different centers with variable uptake. So it was good initial evidence to say this is something that we should continue to pursue. Dr. Karen Chu, my close colleague and friend in Canada, has published great work looking at bi-center implementation of the ICU liberation initiatives there, and showed that it had a positive impact on sedative exposure, that it was feasible and pragmatic, and also some positive impact on outcomes. But what we really need is large multi-center studies that are pragmatic again, because this is a very common sense intervention that requires a lot of different pieces and workflow. So what I can tell you is what we do know is our landscape, which needs a lot of work. And there are areas for improvement, but also areas for us to pay close attention to in our clinical practice. So our PARC PICU study, the prevalence of acute rehab for kids in the PICU study, was a study in the United States of 1,800 children, but also included many countries across the world in the international part of this study. And universally, what we showed is that delirium or a lack of a delirium screen is the only clinical risk factor for an adverse event during early mobility. And I think that's really important because safety is obviously everyone's main concern when you start talking about this stuff, right? I don't want the ET tube to fall out. I don't want, central lines and art lines or desaturations. We found that virtually all of the adverse events that occurred were transient and didn't have an impact on the patient in the short and long term. But you are more likely to lose an invasive device or have an adverse event if you were delirious or hadn't been screened that day. So like, just take a second to think about that. Like positive delirium, it makes sense again, right? If you're not lucid or you're not interactive with whoever is facilitating your mobilization, you're more likely to potentially have an endotracheal tube come out. Um, Lucid patients know they need these devices. They often, including infants, they often don't intervene on those devices because they understand what's happening around them. So keeping patients oriented. We found that in the US, this is really concerning, girls were less likely to receive a PT or OT consult than boys in the ICU. So we have to explore that a little bit more. Luckily, that wasn't the case internationally, only in the United States. But the big take home is that children who had family engagement at the bedside and a physical therapist or occupational therapist engagement at the bedside had the most likelihood of having intensive acute rehabilitation occur. And we have follow-up studies looking at speech language pathologists, which we haven't talked about much here, but are critically important, right? Because as soon as you start keeping kids awake and alert and mobilizing them, they need ways to communicate. So cognition becomes really important. And what I want everyone listening to the podcast to hear is that often we think of SLPs as focusing on swallowing in the ICU, swallowing dysfunction. But then what about cognition and communication? We should be utilizing our SLP colleagues to the highest level of their expertise to help us take care of our patients. So we learned a lot with those landscape studies. What we learned is that early mobility and delirium are the least implemented and recognized within PICUs internationally. So that's really where we need to focus our work, and that's what our upcoming clinical trials are focused on.
Right. Well, it sounds like that's the direction forward. What other questions do you think we'll be looking to answer in the next 10 years of PICU UP and early mobilization in general?
There's no question that once we have the short-term outcomes elucidated, does a program like PICU UP or ICU liberation initiatives, do they have an impact on duration of mechanical ventilation, acute functional outcomes while in the ICU? We have a huge number of investigators across the country that are now doing the important work of delving into the long-term outcomes, which, as you know, are critically important. As mortality continues to decrease in the ICU, our morbidity continues to increase simultaneously. And that's because we're doing a great job of keeping children alive and getting them to discharge, but often with potential ramifications of all of our iatrogenesis and interventions. So the long-term outcomes and follow-up are going to be the most important next step in terms of quality of life and making sure these are patient and family-centered outcomes. We know Karen Chung has also done great work in determining, along with our colleagues in the US, the PICS-P groups and the post-intensive care syndrome groups who are really focused on this of what do patients and families want? And to explore that in a very meaningful way. And that's really the next 10 years of this work.
Wow. So there's a lot to do, but it's an exciting area to be in. And it's very exciting because you're leading us and we appreciate your passion and dedication and inspiration. I think it's, as someone who's been participating in PICU UP for now, our 5-year anniversary is coming up this fall.
Congratulations.
We're working on planning our celebration.
Awesome.
But it's been a wonderful way to be able to get the early mobilization up and running and also continued sustainability. So thank you so much for joining us today. It's great to talk to you.
It was awesome being here. Thank you so much. And the best part of this work is networking and connecting with so many awesome people across the globe. So thanks for the opportunity to talk about this. You can feel free to reach out anytime. I'm on X at Sapna KMD. And you can also just Google PICU UP if you want to look up any resources. I also just should note, Kate, that I also curate a daily list of ICU liberation-based publications on Medline that you can check out. And I'm sure we can put the website in the description for this podcast. Please do check it out.
That's a wonderful resource for folks who are interested in this area. It's also amazing work.
So happy to connect in any way, shape, or form. We'll be having an annual conference focused on pediatric ICU liberation. So please do look out for that. And thanks so much for being a part of this community to all of you who are listening.
Thank you. Thanks.
This has been a production of Open Pediatrics. You can find the resources and journal articles referenced in this podcast in the description. We have more podcasts like this one available everywhere you get your podcasts. Visit openpediatrics.org for more information.